Hi, everybody. Today we are going to be talking about the treatment of offenders who abuse substances. So these will be individuals who may have come into the criminal justice system because of drug-related crimes in the sense that they have possession charges or selling charges, um, or they may come in contact with the criminal justice system because their addiction has caused them to engage in criminal behavior such as violence or theft as a consequence of their substance use. So we know historically that substance use has long been associated with violence and criminal behavior. And alcohol and drugs are estimated to be implicated in about 80% of crimes. So this is a serious issue, not only for the individual and their families, but also for our criminal justice system. So we see, drugs contributing to crimes such as domestic violence, IPV, which we talked about last time, DUI, property offenses, drug offenses, and public order offenses. And it's estimated that about 80% of offenders in the criminal justice system abuse drugs or alcohol. They may not all be addicted, but there is some abuse of these substances. But about half of the people in jail and prison are clinically addicted, meaning they have a physiological dependence on either drugs or alcohol. So you can see that this is a serious problem in the criminal justice system. About 60% of individuals, when they are arrested, test positive for illegal drugs. So there wasn't a lot of very recent data. I think they're going to be gathering data. I think they do it every 10 years, so they haven't published the latest results. But here are results from 2007 from the Bureau of Justice Statistics. But it's estimated that a lot of victims of violent crime perceive that the people who are assaulting them are on drugs or alcohol. And we can see that the number of arrests for possession has gone up dramatically. And this is, you can see with our Get Tough on Drugs kind of legislation starting in the 80s that we started prosecuting people for possession charges. Now, what will be interesting will be as, there's some legalization of certain substances, if we're going to be seeing decreases in these people. And I think we're recognizing that putting people who have substance use problems in prison because they have possession of these substances is kind of counterproductive. And you'll see some of the psychological and the cost consequences of making such decisions. So what we're going to be talking about today are substance abuse treatment programs within prison. So this is a graduating class from the Bureau of Prisons who have completed a substance use program. And so these are programs when people come in, they are deemed to be addicted to substances, and so which contributed to their crime. If you think about the R&R model, that would be a dynamic risk factor, their substance abuse, and therefore they are then kind of asked to go into substance abuse treatment. So as we talked about earlier, these are just some more statistics. We said 80% of people who are in criminal justice system abuse alcohol and drugs, with 50% being addicted. Those who completed treatment within 3 years, 27% went back to prison. Those who didn't complete treatment, 73% went back to prison. So treatment is really great in terms of preventing people from recidivating. So it's something that we definitely need to consider. And if you think about here, this is the cost of methadone maintenance treatment versus the cost of incarceration. So for methadone, we'll talk about a little bit later, is for those who are addicted to opioids. So 1 year of opioid treatment is about $4,700 per person. 1 year of incarceration kind of starts at $24,000 per person. And those are 2006 statistics, so it's gone up since then. So you can see that there's a lot of incentive here for us to be treating people with substance use problems. So basically, we have tremendous amounts of individuals who are involved in the criminal justice system who have substance use problems, and so we really need to expand our current drug treatment programs. And so unfortunately, with larger numbers of people both involved in the criminal justice system and who have substance use problems and decreasing budgets, they have to kind of make choices as to who is going to receive treatment. And so it's the people with the greatest risk. So for those people who have the most addiction, or for whom drugs and alcohol are most closely related to their crimes, or you provide treatment to those as they're closest to release. Unfortunately, currently fewer than 15% of those with addiction receive treatment in prison. Sometimes they can go outpatient once they're released, but we need to make sure, given that we have such scarce resources, that the most people who are in most desperate need of the treatment are the ones that are receiving it. So it's really important that we have accurate assessment instruments, and that speaks to the reliability of these instruments, and making sure that we are accurately assessing who needs those. So there are on-site substance abuse programs, meaning that they take place within the institution in 94% of federal prisons, so that's the BOP, 56% of state prisons, and 33% of jails, meaning that there are organized programs within those institutions. The most common type of substance abuse programs that we see are given within the general inmate population, where they have, kind of treatment programs, and they're kind of pulled out from general population to attend these programs, several times per week. However, there are residential programs, which we talked about earlier, which are the therapeutic communities. So about 70% of inmates that receive treatment for substance abuse get it within the general facility population, so these groups within the prison population. However, about 28% of inmates receive treatment in these specialized substance abuse treatment units. So they are pulled out from the general population, and they now live in special units which are dedicated to the treatment of those with substance abuse units, which are similar to the therapeutic communities that we talked about earlier. 2% receive inpatient treatment if they have severe addictions. And so private organizations operate some of these substance abuse programs because of the lack of training, resources, things like that. They sometimes contract out. So 22% of state prisons, 21% of jails, and 52% of juvenile facilities contract out their substance abuse programming, which, assuming that we are requiring people to provide data, can be helpful. However, we have to maintain quality control whenever we contract out. There are also residential facilities, which we talked about with the therapeutic communities. So these are substance abuse treatment programs within state and local correction and detention facilities, but they're separate. So the main goal are for people who are primarily incarcerated because of their substance abuse, and that's the primary criminogenic need. So you put them in this therapeutic community or this residential facility where all they are doing, is working on their substance abuse. So they are incarcerated for a period of time. It's not generally too long, but kind of 1 to 2 years, which permits them adequate substance abuse treatment. And the goal of these residential facilities is to reduce recidivism by implementing programs that give these individuals who have serious substance abuse programs individual and group treatment, so that they will not go out and reoffend. Because once their drug problem is taken care of, oftentimes their need to engage in criminal behavior has also decreased significantly. The programs generally last anywhere from between 6 and 12 months. Addiction is something that's very hard to overcome. And so, like when we see the celebrities go to rehab for 30 days, that's generally not sufficient to overcome a serious addiction. You not only have to get over the physiological symptoms of withdrawal, but the psychological ones, and also work on the reasons that you started abusing substances to begin with. So there's a lot of work to be done, and that can take a period of time. As we mentioned, it's usually set apart from the general correctional population. It's still maintained as a prison in terms of perimeter, and they still have guards, but the goal really is kind of a therapeutic environment inside. Focuses primarily on the substance abuse problems, and usually uses cognitive behavioral therapy and kind of 12-step program guides in order to treat or address some of the issues, as well as providing kind of vocational and educational skills to the individual. So these residential programs are often called RSATs, and they are, one of the difficulties is that it's hard to get adequate staff to staff these things because it's run by the state. Individuals who work in these facilities cannot have a history of substance abuse disorders, which is kind of contrary to many of the AA models. And so they have a hard time kind of sometimes hiring and retaining staff. One meta-analysis, if you remember, a meta-analysis is when we have the big study where we combine multiple studies together to get a really large sample size, found that there are positive outcomes for in-prison substance abuse treatment programs. People who attend these programs are less likely to be arrested or be placed on higher custody level. And if they receive aftercare, meaning that they help them transition back into the community, because that's a big jump. You're now in rehab, where you're supervised, you're away from the community. Now going back into the community, if you provide them with aftercare and help, they have lower levels of recidivism and relapse. Another thing that I think is fabulous is the implementation of drug courts, because as we talked about, a lot of the people who have substance use problems are not hardened criminals. These are people who have an addiction and which takes over their life and then causes them to engage in this criminal behavior. So drug courts are a way to get people the help that they need and diverting them from the criminal justice system. So it's really a win-win. It helps the individual. They're not going to prison. They don't have their record can be expunged, but it also is a help to us as a community and a society, because A, they're getting help decreasing crime, but B, it also, it costs a fraction of the cost of incarcerating people, so that money can be used for health care, for education, for other things. So drug court started in the late 1980s, and it was largely financial. A lot of the things that we see, the reforms, are largely based on finances, but if it makes sense from an evidence-based perspective, I don't really care why they did it, because, this really does make a lot of sense. And so it was, basically they couldn't keep up with the need of all the people that were coming in contact with the criminal justice system because of drugs, and this was created as kind of an option. So drug offenders were accounting for about 3/4 of the growth in the prison population between 85 and 95, and that was that big spike when we had that gut tough on that war on drugs. So the first drug court was created in Miami, just to get you a little history, back in '89. They exhibited promising results. We now have drug courts in all 50 states, and it really focuses on facilitating treatment instead of putting the person behind bars, and keeping them out of the criminal justice system. So if they complete, their what is mandated to them by the drug court, like they maintain their sobriety, they attend the programs they need to attend, then after the period that is specified by the judge, they can get their record expunged, and hopefully they've received the help that they need and they've now not been in contact with the criminal justice system. Initially, it was primarily geared to non-violent offenders, although we are seeing now some people who've had violent crimes who are going through these courts as well. So this is kind of the process. So the defendant is arrested. They go to a special court and agree to participate in a drug court. The judges in drug courts are specially trained to deal with people with substance abuse programs and problems, and people in the court system also have specialized training working with substance abuse. So they do a thorough evaluation, and there's a team discussion about the person's needs and the person's risk. They then they agree to a plea where going to a drug court is part of that. They now participate in monitoring throughout the process. They'll be giving drug tests. And then, based on mandated to attend programming, and based on whether they successfully complete it, they return to court. If they are completed, then they're done. And if they don't, then they have returned to traditional prosecution, and so they might end up going to jail. So this is really a second chance for people who've gotten themselves in trouble. So drug courts really combine intense supervision by a judge with substance abuse treatment, including detox, drug testing, incentives and sanctions, meaning you can have your record expunged or you can go to prison, as well as case management, so people helping you. So here you can see that people who go to drug courts, which is the lighter bar, after 2.5 years have almost half, not quite half, the recidivism of the comparison group, which is treatment as usual. And the overriding goal of a drug court is to abstain from substance use and not engage in criminal behavior, which is what the majority of people want to be doing anyway. So here are some other data. So we see that people who don't go to drug court recidivate at 48%, 16% for drug court participants, and it's saving between $6 and $9 million a year, which is a significant savings. And we do know that they're less costly. You can see the map up on the right-hand side. That's where all these drug courts are located. They're very much proliferated all over the United States. We see a lot of reduction in costs related to prosecution and jail sentences, and Drug courts cost about $2,000 a year compared to anywhere between 20 and 50K a year to incarcerate somebody. So that is a tremendous savings, and it benefits all of us. So you've probably all heard in the news of the proliferation of the opioid crisis here in the U.S. Um, so opioids are highly addictive. The withdrawal is horrific. People get addicted very quickly after just one or two usages, and the withdrawal is horrible. I remember watching the movie Ray and seeing, the Jamie Foxx's character who portrayed Ray Charles going through withdrawal from heroin. We are now seeing increases of levels because of these increased different type of opioid drugs available on the market. And so this is a very serious problem. A lot of these people are getting involved with the criminal justice system. Now, one of the problems is that detox is so hard that people often relapse. People can actually die during detox, so it has to be very carefully monitored. So what has happened over the last several decades is called a harm reduction model, which means that we are trying to minimize the problem and come up with a better solution, which is not necessarily sobriety, but it reduces the harm to the individual and to society. So methadone is a synthetic narcotic analgesic. You can see the chemical composition on the right. It basically is derived from opium, which is the base for opioids, and it's used in the treatment of heroin addiction. It was developed in the 1960s, and so by these researchers who felt that heroin addicts developed a biological adaptation to opioids so that they needed them in order to feel normal, which is what many people who are addicted to opioids will tell you. It's not that they even get high anymore, it's just that they want to stop feeling so horrible, and that's why they have to maintain their addiction. So it's hypothesized that heroin addicts, even after withdrawal, would never feel normal unless they've resumed some sort of opioid in their system. Now, that is very controversial, as we'll discuss, but at least in the initial stages of withdrawal, something such as methadone can be helpful because it has a longer half-life than heroin, meaning that it stays in the system longer, and it only needs to be taken once per day, and it can be taken orally, as you see in the picture, versus injected. And it's really kind of thought of as some sort of a maintenance medication, kind of like people who have diabetes take insulin. I'm not likening the two things. However, but that this methadone is kind of for people who've developed this addiction to opioids. And so it's not an exact substitute for heroin, but it fills the receptors for the opioids. And so therefore the withdrawal symptoms don't really happen, but you don't get the same high. So you kind of are able to maintain yourself. You're not having the withdrawal, you're not having the high, which allows people to function in society, hence the harm reduction part of it. It's also they're not using needles, which transfer diseases and all sorts of other things. So if you have enough methadone in your system, it occupies enough of those heroin sites of action. So even if you take heroin, it's going to have little effect on you. So there's no point in getting high anymore because your receptors are already filled with the methadone. You can see somebody here come into a methadone clinic where they're getting their drink. Now, usually people who participate in methadone programs will also have some sort of counseling accompanied with it. And they found that methadone can be extremely effective with in terms of decreasing illegal drug usage, criminal activity, making people more socially productive and more psychologically stable. Because if you've seen any videos about people who are addicted to opioids, it completely wrecks your life. It takes over completely. You have mothers who are driving and abandoning their babies in the back seat, things like that. People are not caring for themselves anymore. So basically, methadone helps people lead more stable lives. However, there is, with a lot of these harm reduction methods, a moral debate because basically we are still giving people an opioid, and these are people who are addicted. Oftentimes, people are given less than the therapeutic dose. You have to take it at a certain time every day, nobody gets a prescription for methadone. You have to go to these methadone clinics to receive it. So that impacts your ability to function in society, kind of, and maintain a regular job unless you're able to go there every day and get your methadone. If you don't get a therapeutic dose, you can have withdrawal symptoms, and therefore there may be more of a craving for the heroin, things like that. The other big problem is that if people do get arrested, many prisons don't allow people to continue their methadone treatment because it is a drug. And so then it's the whole problem all over again because now they're going to have withdrawal symptoms. Most of you are probably familiar with AA and NA, which are based on 12-step models. These are the most common form of substance abuse treatment that we find here in North America. One of the reasons is they are everywhere and they are free, which for many people who are involved in the criminal justice system is exactly what they need because, they're also on an outpatient basis. They're pretty much socially acceptable. And so we see a lot of people using both these inside and outside of prison because of the availability and the accessibility of it. Unlike other types of programs where people have to pay, these are available. There's controversy with 12-step programs in that many of them are closed and they don't allow researchers to evaluate them. There are claims that anywhere from 5 to 50% of people who attend AA and NA become sober, but because we're not really allowed to follow up. There's also a self-selection bias in the sense that people, who are more willing to change are the ones that are going to these programs. There's also the controversy that, as you can see from these 12 steps that I've kind of put here before you, God is implicated. Now people, a lot of the times they will take the religion out of it, but you've often heard things like a higher power. It also takes away free will and it uses the disease model of substance abuse, which is somewhat controversial, saying that people who have substance abuse actually have a disease that they are powerless over. And as a psychologist, we believe in free will and people's ability to choose. I'm not saying that there's not power to the addiction, but you always have a choice. And so if you say that somebody else is in control, like a higher power, that diffuses you of responsibility for your behaviors. So these are the 12 steps. Also, you can check them out online. Some classes, I know some of the KSAC classes, that students are actually asked to go to an AA or NA meeting to check it out, to see what it's like. KSAC is it's a certified alcohol and substance abuse counselor. It's a certification that you can get the educational component here for at John Jay. And then if you do the externship, you can get certified by the state and then work in a substance abuse treatment facility. Another controversial treatment is what's called control drinking. It's basically kind of everything in moderation. So we're saying, as you can see from Will Ferrell, here we know that people oftentimes when they have problems engage, don't have the ability to control their drinking anymore. However, abstinence is not necessarily a reasonable goal for a lot of people. And what we see, especially with the AA model, is called the abstinence violation effect. So if you say, you can never have a drink again, inevitably people are going to have a slip because that's how human behaviors are. And then once they have a slip, they've now failed according to the AA model. And therefore, we often see people go on what's called a bender, I guess. I don't know. I always liken it to my problem with sweets because I love sweets. And sometimes, I will always eat sweets in moderation. However, sometimes, you eat more than you want to and you're like, ugh, I've already eaten so much. I might as well eat the whole thing. Now the same thing happens with substance abuse. But if you think about everything in moderation, then you can say, well, maybe I can drink, a drink here, a drink there, as long as I don't do it too much. Now, what do you think of that? It is controversial. It's called BSCT, and it basically consists of you monitoring your drinking and urges to drink. You set a goal for yourself, and you work on controlling your alcohol and learning how to refuse drinks. You get rewards when you meet your goals, and you don't get rewards when you don't. You kind of recognize some of the things that trigger your drinking behavior and you work on changing those things. You figure out what situations make you drink and how to kind of target some of those underlying things. Cognitive behavioral therapy is used to do that. And you also talk about relapse prevention. So once you're drinking the way that you want to be drinking, how do you make sure that you don't end up overindulging again and having those substance abuse problems? It's currently the most studied of the controlled BSCT is the most studied controlled drinking approach. There's another meta-analysis that was done, and they found that this kind of controlled drinking is superior to non-abstinence interventions and no interventions at all. There also is some evidence to suggest that controlled drinking tended to be better than abstinence interventions, but not significantly. So, for some people, abstinence may not be a realistic goal. For those people, this may be the right approach to take. Most of the treatment programs that are operated in prisons have some component of cognitive behavioral therapy, which we talked about multiple times in the course of this class. So you get the psychoeducation about substance abuse, you learn about problem-solving skills, decision-making skills, and social and communication skills, so that you're recognizing some of your vulnerabilities, how to communicate more effectively so that you get what you need without using substances, and then, changing your thoughts and behaviors. The last thing we're going to be talking about today is motivational interviewing. Some of you may have heard about that in your other classes, but that is a technique that's used very frequently in substance abuse treatment to get people who are not ready to change to get to that point of action. You may have heard about Prochaska and DiClemente. They have a stages of change model, which is presented here to you, where they have 5 different parts of change. So you have the pre-contemplation, where people are not considering or they've rejected change. They're like, I am abusing substances and that's the way it's going to be. You then have the contemplation, where you are thinking or considering change. You're not ready to change yet, but you're starting to debate it. That's where I am right now with my exercise plan for the spring. Planning is where you actually have decided that you are going to make a change. You have not made the change yet, but you start planning what you're going to need to make that change. Action is where you start making the change and putting those positive steps into place. And maintenance is when you have actually made the change, you're seeing positive results, and you are continuing with very little support. We then also have relapse, when you revert back to old behavior patterns and the cycle can repeat itself. So motivational interviewing is an evidence-based intervention to get people from these pre-contemplation stages to the contemplation and action, planning and action stages, so to get them there. And so there's a variety of different ways that you can do motivational interviewing. Some of them are brief, 30-minute interventions. Some of them are multiple interventions. It can be ongoing counseling. It depends on where the person is in terms of their readiness to change. And a lot of that is based on a client assessment. So here are some techniques that you do with motivational interviewing. So, you express empathy with the client. So you're not telling the client you need to change, because change has to happen from within. But you kind of use these techniques to help them get to a place where they're ready to make the change. So you understand kind of here's an example with smoking. So what I hear you saying is that you're tired of being lectured about smoking. Tell me about why you feel this way. So they're kind of sharing with you, you're expressing empathy, you're kind of getting on their side. And then you develop discrepancies, meaning you kind of talk about their goals in the future. So, you want to work, you want to have a job, and how does that work with your opioid addiction? Or how do you see smoking fitting in with your goals? And then you kind of recognize that your goals for yourself don't necessarily mesh with your current addictive behavior. You don't want to argue with people. And so you kind of make a statement. The single best thing you can do for your health is to quit smoking, and I'm here to help you when you're ready. You're not going to push the person to get ready whenever they're not. You roll along with resistance when it comes, because people are going to push back on you. So it sounds like you're having a lot of possible stumbling blocks to cutting back on your smoking. What could be some of the possible solutions? So, you acknowledge that that's what's going on, but you kind of work with them on it. And then when they start making this change talk, like they start thinking about it, they're getting to the planning stage or contemplating the change, you reinforce that. So I'm really impressed that you're thinking about cutting back on smoking. I want you to know I believe you can do it. Let's plan to meet in a month and see how things are going. And so the people, this is a process that takes place. You can't force somebody to change, but you're getting those wheels churning. A lot of the skills that are used with motivational interviewing are using open-ended questions, affirming kind of what the patient is saying, reflective listening, summarizing, and informing and advising. So whereas cognitive behavioral therapy is a very active technique where the person's already engaged with you, they've agreed to work, here we are getting people to kind of become active, but we're not pushing them. We are really getting those wheels moving. And so these more passive techniques and getting people to kind of recognize the discrepancies between what they want and where they are really can kind of move themselves along the way. If you're interested in this, it's something that's really useful. It's not only used in substance abuse treatment, it's used in all sorts of treatment interventions to get people who have, depression, anxiety, all sorts of things to get them kind of going in the way that they want to, and getting ready to make those changes.